جميل.
مش مشكلة، محدش أصلا مهتم بس.
هذا الشيء.
محدش أصلا مهتم بس. استنى أخش أعمل فيو. أوه نايس.
ممكن تخش دلوقتي يا حسام؟
دخلت أهو.
ايه؟
لسه داخل في حالة.
تقدر تعمل تشات؟
لا ولا لايك حتى.
لا والله.
لا لايك.
طب بعدين مش عارف.
ايه ده؟ لا اقدر.
تقدر تشات؟ طب ابعت لي كده. اشتغل اهو. نايس. اوكي حلو. Okay, hey guys, I've been trying to do a live stream for a long time to like stream my USMLE Step 2 prep, but finally I'm here, gonna do a live stream. So if you have any questions for me, just let me know. I have about 2,000 questions from Kaplan. I want to finish Kaplan first and then go to AMBOS and then UWorld, MBMEs, CMS forms, or CMS forms, MBMEs, and then just take the exam. So let's do it. Which of the following is the most appropriate next step of management? Okay, so this question, you gotta know what's wrong with the patient and what does the patient has in order to know what's the next step. So 33. Okay, that's biliary colic, right? Okay, that's biliary colic. Probably like cholangitis too. Yeah, so that's not biliary colic, that's cholangitis. She had biliary colic before, but now she has cholangitis. Because what happens in biliary colic is that the gallbladder contracts and one of the stones blocks the duct, right? And the duct, now the bile cannot go anywhere, so it accumulates and the bacteria grows and causes cholangitis. So done ultrasound says gallstones, thickened gallbladder. Okay, that is definitely cholangitis. What's the next step? What are we gonna do? Of course, we're gonna give antibiotics. I'm gonna drain the fluid inside the gallbladder, and then we're gonna do cholecystectomy. Cholecystectomy in 72 hours and 7 days. CT scan. I've seen this question, like a similar concept before. It's gonna be 72 hours. Not gonna wait that long. It's gonna wait 72 hours. Okay, so she has acute cholecystitis, blah blah blah. Yeah, so we do early cholecystectomy within 72 hours to reduce associated complications. Okay. 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 this case, like, this question is easy for me, so I'm not gonna waste a lot of time on it. I'm just gonna read the education objective. You ask yourself, if this question or any similar concept came to you again, would you be able to solve it again? In this case, you know, you just acute cholangitis, blah blah blah, Murphy sign, LA, whatever. Okay, let's see the next one. Which of the following is the most appropriate next step of management too? So I would see here urine sediment shows crystals in the shape of rectangular prisms. Okay, nitrite positive, leukocyte. Okay, that is true white kidney stone. If you've seen, like, for step 1, if you studied step 1 well, you would know this question easily. You guys know it's true white kidney stone, which is magnesium phosphate something. Struvite kidney stone. What is it made of? Magnesium ammonium phosphate. Yeah. So this is like an infection here. Coastal vertebral angle tenderness bilaterally. Okay, physical exam. Okay, so what do we give? So this guy has true white kidney stone. So if you guys know how it looks like, it's just surgery, I guess. Yeah, it's very big. There is no way you can treat it medically, right? There's no way you can treat it medically or fluids or whatever. This is an infectious type of kidney stone, so you got to do surgery. All the other ones do not work. Don't make sense. Oh wait, where's my mouse? Yeah. Okay, I know this one. This is easy. I'm gonna move on. The following is the most appropriate treatment. Add this time. Okay. MI. Okay. Okay. Further studies shows lactic acidosis, cardiac index, blah blah blah, wedge pressure 29, high pulmonary and systemic pressures. Ultrasound of the pericardial sac is unremarkable to define the most appropriate treatment. Okay, I think this guy just has cardiogenic shock. I mean, cardiac index, if that's a low cardiac index, that means the heart cannot contract well, so it has low. And then high pulmonary and systemic peripheral vascular resistance. When the heart is failing, you know, the peripheral arteries just vasoconstrict. Ultrasound of pericardial sac. Okay. You see what happened here? Yeah. Okay. Just gonna move on. Okay, outstretched hands, so Fuchs injury. What is the management? I don't think you need to just open it. I think that's so, like an easy fracture. You just reduce it. Okay. I don't think these are good answers though. Oral midazolam. Lidocaine works, but I think we gotta give him something for like the crying and that he's scared and stuff. So fentanyl. No. That is a possibility, and that is a possibility. Analgesic sedative. I'm gonna go with this. Oh no. Okay, that question I have no idea about, so I'm gonna study it as if I have no idea about it. Or solely that. Procedural sedation at a minimal or moderate level is adequate. No, procedural sedation. That's very not clear. Very unclear. second. I'm gonna. عايز عيد مبارك حبيبي. I don't know what else to do here. If I was in Egypt, I would definitely not study right now. But I have nothing else to do in here in Buffalo. Okay, it's a lot of stuff here. Okay, so we have minimal sedation, moderate sedation, deep sedation, general anesthesia. In minimal and moderate, the patient doesn't need like intubation or whatever, right? He can keep his airway patency and reflexes and everything. So minimal and moderate. This level is indicated for children or adults who have not fasted before the procedure, or patients who do not require a deep level of sedation. Okay, nevertheless, procedural sedation should be performed by appropriately trained personnel and only when equipment for resuscitation measures is readily available should the need arise. Okay. For minor surgical procedures such as suturing, uncompleted administration of short-acting or long-acting benzo, midazolam or diazepam respectively by the oral or rectal route provides sufficient sedation. IV access is not required. IV midazolam or diazepam can be used. That more intense pain or discomfort such as complex. Okay, what's the difference between complex lacerations versus simple? Guess there's a difference. Okay, simple laceration. Okay, that's not a thing. Simple laceration, reduction of fracture. Okay, procedure, sedation in children. Goals: manage anxiety, discomfort, prevent excess patient movements for the safest and best procedural outcome. Yeah, anxiety because he's crying and frightened. Discomfort and excess patient movement, the safest and best procedure. I need to see more questions of this. I don't understand. Safe level of procedural sedation. mean, what pisses me off is that they're saying it's minimally painful, even though he's crying and frightened. Okay, so is procedural sedation minimal or moderate? I think so, right? Minimal or moderate? Okay. Hmm. That's an opioid, isn't it? Okay, never mind. Dexmedetomidine. 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 Alpha agonist. Sedative. Okay. Having a stroke right now. Medically induced temporary depression of consciousness. Yeah, consciousness. Analgesia is pain, right? Consciousness. Sedation is like decreasing consciousness. Analgesia is like decreasing pain. Okay, never mind. Alpha agonist having sedative, anxiolytic, hypnotic, sympatholytic properties. Painful. If you have painful intervention, now you have you need analgesia in addition to sedation, right? But if you have non-painful or minimally painful, you just need a sedative, you know, a quick sedative, like here. Okay, so the reason we didn't pick A and B is because, or is that these, this injury is minimally painful, right? So we don't need an opioid, we don't need an analgesic, right? I just want to see, is midazolam like, no analgesic, okay. So we don't need analgesia here, that's weird. Wow, we don't need analgesia at all. I think we're just going to add lidocaine. Let me see why lidocaine is wrong. Let's see why lidocaine is wrong. Where's the answer? Lidocaine is the local anesthetic, not a sedative or an agent typically used for procedural sedation. Local anesthetics used to numb the areas for procedures without causing, okay, I know that, altering. In this case, the patient is crying and frightened. Procedural sedation into cholangitis. Okay, so I guess we're not gonna. Okay, I guess the question is just asking about what sedation is gonna happen. I guess, right? Yeah. What sedation is needed? Lidocaine is just an analgesic. All right. I think I understand this. Procedural sedation at a minimal or moderate level is adequate for minor procedures. Let me just understand what this is. Okay. So let's see the question again. An otherwise healthy 5-year-old, small, to the hospital because he had a 3-centimeter laceration to his forehead. Patient is crying, frightened. Practitioner decides to perform procedural sedation before suturing the laceration. Perform procedural sedation. Okay, all right. Sorry, sometimes these questions are just fucked up. Right, so the question is asking, right, I have a patient here who has an injury, a laceration, whatever. So we need to do sedation, right? We need to sedate him. And the question is asking about, are we going to sedate, like how are we going to sedate him? Okay. Probably we're going to use lidocaine in doing the procedure, like the suturing itself. But the question is not asking about that at all. It's just asking about the sedation part. So I think I got it. Procedural sedation at a minimal or moderate level is adequate for minor procedures that require no significant pain management. Okay. All right. I think that makes sense. So in this case, oral midazolam is going to be fine. Fentanyl is an opioid, isn't it? Help is available. Fentanyl mechanism. No, come on. It's an opioid, yeah. Just making sure. Okay, I'm gonna read that again. Analgesia: no purposeful sedation, minimal sedation, moderate sedation, deep sedation, general anesthesia. By definition, during minimal or moderate sedation per the above levels, patient is able to maintain airway patency, protective reflexes, responses to physical stimuli. This level of sedation is indicated for children who have not fasted before the procedures, patients who did not require deep levels, who have not fasted. Okay, I hope I get like more questions like this, but Eid Mubarak Habibi, GBZ. Thank you, bro. Alright, let's see the next question. I'm gonna mark this. I'm gonna go back to it just in case. So as you see, guys, I've spent what, 15 minutes on this question? Because I don't remember. Like, I don't remember anesthesia. Like, I remember in med school I completely skipped that part, I guess. So I'm trying to learn the difference now between analgesia and analgesia and sedation and analgesia, right? It's just in the back of my head, but like needs recall. So if you have a question like that, that means it's just a weakness. You gotta spend some time on it, right? So yeah. Habibi Fantasm. Thanks, bro. Eid Mubarak to you too. Okay. See you next one. Which of the following is the most appropriate treatment for this new good anatomy resources? For the USMLE step 1 or what? Or like in general? For the step 1, I don't recommend any resources. Just do questions, because the anatomy part is like very small, so it's not worth it to just get Gray's Anatomy or stuff. It's not worth it for you. Hi, LP Mila. Hi, bro. Hi, brother. Eid Mubarak to you guys. Okay, which of the following is the most appropriate treatment for this new development? Let's see. 44-year-old is recovering from a mild episode of acute ascending cholangitis secondary to choledochocolitis. Okay, this is one of my strengths, actually. Let's see. When seen initially, she has spiking fever, blah 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 blah. All this finding subsided rapidly after she was placed in IV antibiotics. At that time, sonogram of the eye shows presence of gallstones, but the diameter of the biliary duct was normal. Because she's suspected of having passed a common bile duct stone, plans to perform an ARCP was cancelled. Okay, while awaiting elective cholecystectomy, she again develops a fever, leukocytosis, and her liver function shows minimally elevated. Okay, while repeat sonogram shows no change in her bile ducts, the 6 centimeter cystic cavity in the right lobe of the liver. Okay, that's bad. That's abscess for sure. That's liver abscess. Okay, wait. So okay, one second. I'll solve this question and answer your question. She had ascending cholangitis, right? And ascending cholangitis, she was placed on antibiotics. A sonogram showed gallstones in the gallbladder, so it makes sense that she had another gallstone in her duct. She was suspected of having passed, but her SP was cancelled while awaiting. Which of the following is the most appropriate treatment for this new development? 6. Okay, so they're just asking about the treatment for this abscess. All right. Okay. So either it's open surgical drainage or percutaneous drainage. I don't. It's a liver abscess. I think it's just percutaneous or open surgical. I mean, it's going to be a major surgery if you just open up the thorax, right? Percutaneous? I think so. Yeah, open surgical looks major. But I'm thinking about, when you have this abscess and it's dangerous that you put the needle in and you you pull on the abscess and you have like pus spreading in the body. It also depends on the location though. Right lobe of the liver. Okay, let's go with this. All right, let's see why it's not D. Open surgical drainage is not preferred for a liver abscess unless there is an underlying disease that requires primary surgical management, an inadequate response to catheter drainage, and viscous abscess contents precluding successful percutaneous damage. Okay. All right, let me answer your question. Would you suggest UWorld with throughout revision of all the question as a sole source for step 1? I mean, it depends on whether you have a good foundation. Okay, so let's talk about the game of the USMLE, right? If you want to get good at the game, you solve a lot of questions. If the questions make sense to you, so for example, you're doing questions and you've gone through these material in med school and you understand everything perfectly, you just need these small details to fill in. Yeah, for sure, UWorld is definitely enough, more than enough. And you can add in, pathoma or something on it. Yeah, a lot of people just use UWorld. If you're in the US medical school, they don't go through all these resources that we go through because they've gone through like the material themselves, So yeah, definitely I would recommend that. Okay, good job. We got it right. Percutaneous drainage. Let's read quickly. Liver abscess. Okay, I got it right. It was a liver abscess. Biogenic. Faster, carries less morbidity, has shorter recovery time. The two most important differential diagnoses. Okay, whatever. That's an easy one. I mean, not really. Whatever. Which of the following represents the proper technique for minimizing complications? Okay, a thoracentesis performed. So we're trying to minimize complication of thoracentesis. Holy shit. Oh my god. Insert the needle in the mid-axillary line just above the rib and remove 1 liter of fluid slowly to improve her. Okay, what does she have? Progressive shortness of breath. Pulmonary examination shows decreased breath sounds on left side. Okay. Left-sided pleural effusion, large left-side pleural effusion. Okay. All right. So we have mid-clavicular line and we have mid-axillary line. So I don't know. Like, that's new to me. So let's just take a guess here. Right. Mid-axillary line is like right here. Okay, that's I don't think it's mid-axillary at all, to be honest. I always see the picture, like if you Google the picture thoracentesis, you'll see that like the picture in the back. So I don't think it's mid-axillary. Sorry, I don't think it's mid-clavicular line. What the fuck is that? Yeah, mid-clavicular. That's just a total guess. So we're using our test taking skills here. Happy 8 to you too, Rana. Thank you. What's the best way to take quick notes from UWorld so I can revise all in step 1? If you have the online UWorld, they have a very nice Anki add-on. You can just, if you have any incorrect questions, you can just go to the cards, the incorrect cards, like directly. If you don't have UWorld online, I think what I used to do is that I used to open like Anki, right? And whenever I have a question, just do that. Click on Anking, all right? And just search the deck for whatever information you want. Let's say liver abscess here. Okay, and we'll have a lot of cards here. And then I activate the cards. You can do that, but that will take a lot of time. Or you can have a copybook. I used to do that as well. Like I used to do Anki sometimes, and I used to do the copybook sometimes. I have a copybook to just write down the notes. But to be honest, just go through the questions. Do questions a lot. Yeah, I think so. Okay, insert the needle in the mid-axillary line just below the rib. Okay, we have above the rib and we have below the rib. I know that one. Below the rib, no. Above the rib, yeah. I think it's above the rib, isn't it? Because there's vessels and nerves under the rib. So I'm not gonna put it under the rib. As rapidly as possible. I think slowly here. Slowly. Okay, I hope this is right. Oh god, this is right. Okay. See guys, I have not, yeah. I just remember this picture, literally, like I had this picture before, and I said, okay, it's not from like anteriorly. You don't put the needle here at all. You put the needle like from behind, so it's not mid-clavicular line, right? And then I said, okay, so I eliminated like E, F, G, H, right? And then insert the needle in the mid-axial line just below the rib. I said it's not below because, you know, I'll show you the picture here. 1 second. Below or above the rib. Okay. Yeah, see this? So under the rib, you have these, like, these vessels. Yeah, that's a nice picture. If you put the needle under the rib, you're going to pierce the nerve, you're going to pierce the artery and the vein. But if you go over the rib, there is nothing. You can easily go over the rib. Okay, so one last question. I hear from a lot of guys saying that they do a passive first aid. What does that actually mean? That means literally just reading the entire first aid. Like, you know, when you just read very quickly over a week or something? Yeah, that's a first pass. Or a passive first aid. That's like passive learning as hell, you know? I never did a passive first aid. I never did that. Okay, that's good. Which is the next step? 4 days after the aspiration of the mass, returns to its previous size, which is 26-year-old woman. Of course. Thanks for joining, bro. Thank you. Okay, left-sided breast lump that becomes painful each month shortly before her menstrual cycle begins. I think that is, what is it called? Fibrocystic changes. She also notes some occasional clear discharge from the nipple of the left breast. Her menstrual cycle regular, occur at 29 days interval with regular flow. Okay, so it grows after each month. Core needle biopsy. I mean, it's nodular here. I think reassure the patient. This is fibrocystic disease. Oh no. This patient has fibrocystic. Okay, I got the diagnosis right. This patient has fibrocystic disease. The etiology is unclear. However, it's thought to occur due to hormonal imbalance. Okay, cyclical premenstrual breast pain is usually relieved with the onset of menses. It can be also associated with non-bloody clear nipple discharge. Yeah. The the most commonly affected area appears to be the upper outer quadrant, which may be unilateral, bilateral, focal. This is going to be tender, nodular, ill-defined, ultrasound, or systemic. Okay. So let me see something. So the management failure of drainage should prompt repeated attempts at drainage. This is not fail. This didn't fail. Final aspiration turns clear, bloody. 4 days after the aspiration, the mass returns to its previous size. So why did we repeat that? Breast dysmorphia. I don't understand. Oh, okay. I misunderstood the question. A final aspiration turns clear non-bloody fluid. So it went down, and then after it went down, it went back to its previous size too. Okay, so it grew up again, so it accumulated fluid again. Okay, that makes sense. So now, yeah, you repeat the aspiration. Okay. All right, makes sense. Oral contraceptive pills. Why are OCPs used to treat fibrotic disease? Oh, okay. So yeah. It's used because the hormones of menstruation or the menstrual cycle are the ones that cause the fibrocystic disease to happen. So if you give oral contraceptive pills, you're decreasing menses, so you're decreasing, the menstrual cycle, in addition to the fluid accumulating. Okay, that makes sense. Breast experiences with swelling in the upper, seen in fibrocystic changes. Okay, let me see if it's knocking here. Which of the following is the most appropriate diagnostic test for this patient? I think that's mesenteric embolism, right? The woman has PAD, peripheral artery disease, diabetes. Then she had like a sudden severe abdominal pain for 6 hours after she ate breakfast. So that makes sense when like the GI is doing much work, much digesting. It doesn't improve. Nausea, vomiting. Positive rebound tenderness. Okay, that means what the fuck? That means peritonitis. What? Did it rupture or what? Rectal examination is positive for occult blood. Yeah, I think that's just ischemic. Oh, the lactate is I. Yeah, that's. I think CT angio. Colonoscopy. I mean, the bleeding doesn't have to be in the rectum. Colonoscopy will not test for the small. It probably is the small intestine. Ultrasound doesn't work. Upper GI endoscopy. I feel it's CT angio. Hopefully. Okay. Yeah, mesenteric ischemia. Acute mesenteric ischemia. Okay, that's an easy question. Alright, CT angio. Anticoagulation analgesia. We're going to the following is the most appropriate next step of management. So you give her anticoagulation, we'll give her analgesia. Positive rebound tenderness. I'm not sure if that's like rupture. GI rupture or whatever. I don't know. Angioplasty. I don't think so. Antibiotics. Could be antibiotics. Laparotomy. I mean, if the wall of the GI tract is edematous, that will increase the risk of the, the bacteria to move from the GI to the blood. Laparotomy. Observed with long-term coagulation. You know why these questions are hard? Because I don't understand what is the next step. Like, where is the next step that you mean? Is it like, anticoagulation, and analgesia. I feel it's laparotomy because of that. Okay. Long-term anticoagulation. Thrombolytic therapy. Okay. Yeah, that's why I picked C, because there's a positive rebound tenderness. Okay, did it rupture or what? What happened? Complication of acute mesenteric ischemia, bowel necrosis, perforation and volvulus, peritoneal signs, rebound tenderness. She requires okay, so any of these complications may have occurred. حبيبي عمار صح؟ Mamar, I think you عمار. Thanks حبيبي, انت طيب صح. Okay, peritoneal signs. Alright, got that. Let's just eliminate the other options because I feel like I would have picked some of these. Choice E. This patient most likely has an arterial thrombosis of a mesenteric artery. Thrombolytic therapy can be attempted if CT shows mesenteric arterial thrombosis. Okay, so angioplasty is not urgent, but it's done, right? Okay, that makes sense. Okay. Which of the following is the most appropriate next step of management? That's intracerebral hemorrhage. Okay. 1 month of pancreatic cancer. Sharp pain on his left side with inspiration. There's no radiation pain. There's no history. There's no nausea, vomiting, heartburn. He denies fever or cough. He has a history of hypertension treated with blah blah blah. Radicals are heard in his lung field. Thank you. لا يا صاحبي انا ما اقدرش انسى حبيبي. انا فاكرك اهو، انا قلت لك انت عمار، بس ما كنتش عارف ان انت اسمك على اليوتيوب مامر برضه، فاكر على انستجرام بس. اوكي. Okay, so this guy had a pulmonary embolism, right? He had a DVT, isn't it? Okay. All right, so if he develops any bleeding from anticoagulation, you can't give him anticoagulation, right? So no further management. No, you give IVC filter because this patient probably had the pulmonary embolism from the DVT, from a DVT that he didn't present with a DVT, but definitely, like, where else could you have, an embolus? It could be a femoral vein, whatever the embolism is. So you have to prevent any more embolism from coming using a filter, right? So I hope that's okay. Let's go. Okay, that's right. All right, so anticoagulation is contraindicated. You don't give anticoagulation, you give IVC filter. Okay. And that's intracerebral hemorrhage, right? Because of the anticoagulation, so that is easy. All right. Which of the following is the best next step in management of this patient? A fine needle aspiration of the mass was performed, which showed squamous cell carcinoma. Which was the most? Okay, 65-year-old man, a neck lump. Okay, that's head and neck squamous cell carcinoma. That's easy, I guess. The patient has a history of ulcerative colitis. The mass is palpated in the neck or in the supra sternocleidomastoid muscle at the left hyoid. Mass is non-tender, firm, and non-fluctuant. The overlying skin is normal. No other masses are palpated. Okay, so this is a metastatic mass. What we're seeing here. So we gotta know where's the origin of this mass, right? Where does this mass come from? Is it from the pharynx, from the larynx, whatever? So we do endoscopy. We do triple endoscopy. We do laryngoscopy. We do bronchoscopy, and we do. Is it endoscopy? So we're definitely going to do laryngoscopy. Any of these are not important, I guess. Yeah. Pain. Yeah, that's an important sentence, by the way. Painless masses in the neck of older patients are considered to be neoplastic until proven otherwise. In older adults, 80% of painless, firm, persistent masses are metastatic in origin. Most of these masses are squamous cell carcinomas arising from the upper respiratory or digestive tract. This patient's age, long smoking, and drinking history is compromised. Okay. So panendoscopy, yeah, esophagoscopy, bronchoscopy, laryngoscopy. You do these three things. Smoking and drinking, immunosuppression, blah blah blah. Okay, that's an easy one. 71-year-old woman is brought to the physician by her daughter. The daughter reports that 3 days ago her mother began to report right upper quadrant abdominal pain. Okay, I was unfocused. 71-year-old daughter reports that 3 days ago her mother began to report right upper quadrant pain. Did not want to eat, decided to rest in bed. The daughter recalls that her mother reported chills, nausea, vomiting. Physical examination shows an obtunded woman with square icterus. Her temperature is 40. She is hypertensive. The woman has severe pain to deep palpation in the right upper quadrant and rebound tenderness. Ordo. Yeah. 22,000. Holy shit. Okay, so she is hypertensive, she has a fever. So that's definitely Raynaud's pentad, acute cholangitis. The woman has severe pain to deprivation. So what is the treatment of Raynaud's pentad? It's not elective cholecystectomy. I think it's emergency decompression of the. Okay. Yeah, that was right. Diagnosed ascending cholangitis, and ascending cholangitis caused Raynaud's Pentad decompression of the common bile duct. Why is E wrong though? Emergency surgical removal stone. So I better drain the thing. Okay. Which of the following is the best test to confirm the patient's diagnosis? 55-year-old man comes to the emergency department because of 12 hours of abdominal pain, fever. 12 hours of abdominal pain and fever, been gradually increasing in severity. The pain is in the right upper quadrant, cramp-like, associated with occasional episodes of vomiting. Okay, so that's definitely his temperature is 38. Yeah, that's acute cholecystitis. Physical examination shows extreme pain, blah 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 blah. Sclera. Which of the following is the best to confirm acute cholecystitis? This be uploaded on the channel. Yeah, I guess so. But you know, it's not a purpose. I'm just studying, you know. So the purpose of this is first to document my my journey, like to teach people how I study personally these questions, and second to just, you know, whenever you feel demotivated, you can just come and hop on and study along with me. These are the two main reasons. But yeah, you can see it on the channel as a default. Okay, blood cultures. No, not blood culture. No, blood cultures. Comprehensive metabolic panel. CT of the abdomen. I feel it's right upper quadrant ultrasound. It's very fast, and you can. Yes. Okay, that's right. Cholangitis. No, this is not cholangitis, is it? This is cholecystitis. What? Abdominal pain, fever. The pain is in the right upper quadrant, cramp-like, vomiting, similar episodes of pain. Tenderness to palpation of the right upper abdomen that worsens of inspiration. Diaphoretic and... Oh, there's jaundice. My bad. Yeah. Okay. In cholecystitis, you don't have jaundice. Well, sorry, I got up to make milk tea. I want a good resource to see anatomy pics. Oh yeah, I was gonna finish this block and get some coffee because I actually didn't sleep at all since yesterday, because the day before I slept 19 hours for some reason. Yeah. I want a good resource to see anatomy pics because a lot of books don't show it in a perfect way. Yeah, I agree. I hated anatomy when I was taking it in med school. I still suck at it. But it's not really important for the USMLE because most of the USMLE is internal medicine, like the basic anatomy. So any pictures you can just Google or just see on the UWorld question bank. So I wouldn't worry about it if you want to come to the States to practice. But if you want to be a surgeon, yeah, for sure, being good in anatomy is good. Okay, okay, guys. So the difference between cholecystitis and cholangitis is, so here's the gallbladder, and here's the common bile duct. If you have a stone here, the bilirubin will continue up, right? And you'll see it in the blood, causing jaundice. But if you have cholecystitis, the drainage of bile is normal, so you don't get jaundice. So yeah, this is acute cholangitis. I bet. I need it for MRCS. Oh, um, let me think. You can use these atlases. I used to use this in med school. You can use it. Sometimes it's helpful. Um, where do you live? Do you live in Egypt or where do you live? Yeah, Egypt. Okay. Uh, I would have told you like get this, but this is expensive. Like if you convert the USD to Egyptian, it's gonna be, yeah. Sadly, I understand, bro. It's do you have any green card or anything or? Oh, you want to MRCS? You want to go to London, right? Um, do you have any visas? I mean, I hope you leave it soon, inshallah. You know, I was counting the days when I was in Egypt to just come here. But to be honest, it's so boring here. So, yeah. Okay, I'll actually look it up and don't say that, bro. You're not stuck. Uh, you know, it's just a phase of life. You know, you're not stuck, man. I mean, just be a good physician. Everybody will want you. You know. I'll look anatomy like apps up and I'll tell you about it. Okay. Anyway, which of the following is the best initial treatment for this patient? Okay. I mean, if this is acute cholangitis, I was gonna say cholecystectomy, but this is not cholecystitis. So, um, I think it's ERCP, isn't it? To just remove the stone. Lithotripsy, no. Antibiotics. Percutaneous biliary drainage. This would be helpful if it were like emergency. I think it's ERCP. No. Okay, wait a minute. Alright, before we read the explanation, why the hell is IV antibiotic? Okay, like best initial, okay. Best, alright. We're definitely gonna give antibiotics like in the beginning. You're welcome, bro. Thank you so much. Okay. ERCP, but ERCP is definitely a treatment, though, isn't it? ERCP is a treatment. It's almost always performed for patients with cholangitis, but it's not the best first treatment. Okay. Okay, that makes sense. Providing antibiotics comes first as it's faster. Allows the patient to be stabilized prior to procedure. Okay, that's fine. All right. Actually, you know, I was in the beginning. I get so angry when I get questions wrong, but after that, I realized that the more questions you get wrong is actually when you learn. So yeah. Yeah. So you give antibiotics. I think drainage is also a good answer. Why isn't drainage? Percutaneous biliary drainage is a treatment option for early patients. Okay. Yeah, critically ill patients, like I said. You wanna. Okay. See, next question. I want to finish this Let's block quickly so you can go get some coffee. So the following is the definitive management of this patient. Okay, definitive management. Now we're talking. For sure cholecystectomy, because you'll have biliary resection. No. We said it's not a definitive treatment. Sphincterotomy? No. I think it's cholecystectomy because there's a lot of gallstones coming down. Okay. Cholangitis due to suspected gallstone obstruction requires urgent ERCP and sphincterotomy to decompress. Placement of biliary stent or drain or other options that can be undertaken. How is it not a cholecystectomy? I don't understand. Important to prevent the recurrence of cholangitis secondary to gallstones. However, this is not the definitive management of an episode of cholangitis. Yeah, bro, but sometimes mistakes are annoying, like this one. It's important to prevent recurrence of cholangitis secondary to gallstones. However, this is not the definitive management of an acute episode. Yeah, sometimes I get annoyed. One second. Sphincterotomy. Indications. Sometimes I don't believe that, when I get the question wrong. This is a very stupid question. Don't you think? It's a very stupid question, actually. Actually. The definitive, maybe because he already has stone in the duct. Yeah. Yeah, I agree. Okay, that makes sense. Thanks. That makes sense. So we gotta deal with what he has first. After we remove the stone, we then remove the gallbladder. Okay. But that's where I don't understand. They say definitive management. So definitive means like the end of it, ending the condition, solving the condition, solving the problem. The problem is he having a lot of gallstones that keeps Okay. Alright, I wouldn't really worry about this question. This is stupid, to be honest. which of the following is the most appropriate management for this patient's condition? Is that a stone? I think that's a stone. 2 stones. 51-year-old woman with a history of diabetes mellitus comes to the emergency. Abdominal pain. One day, the pain is sharp, intermittent, and non-radiating. Okay, intermittent and sharp. That is a stone pain, non-radiating. That's not a stone pain. She also reports nausea and vomiting. Temperature is 38. Tenderness to palpation, the right upper quadrant without guarding or tenderness. Right lower quadrant, like here. Right lower quadrant without guarding or tenderness. There's tenderness at the right costovertebral angle. Okay. Abdominal CT. Nitrites are positive. There is red blood cells. There is white blood cells. Leukocytosis. Abdominal CT. Which of the ones is the most appropriate management for this patient's condition? So he has fever. So I think that is pyelonephritis because of a stone. All right. Which of the ones is the most appropriate management for this patient condition? Admit for observation. I mean, she's old. Okay, let's leave that. IV antibiotics. Okay. Nephrostomy tube. Open surgical removal. Yeah, nephrostomy tube. Open surgical removal. How large is this stone? No way. It's shockwave with a trypsy. No way. Open surgical removal. No, we gotta treat the pyelonephritis first. IV antibiotics. The antibiotics would be useless if we didn't put the nephrostomy tube. Please God, make it right, please. Oh. Okay. The correct answer is okay. CRA. Is there a lag? Are you on the same questions like I am? Yeah, it's nephrostomy tube. So if there is a stone that caused because I got like 4 questions like this one. I used to get them wrong all the time, until I stopped screwing around, and then I said I'm gonna study these questions well. So what happens is when you have a stone and a stone causing pyelonephritis, I used to think, okay, give them antibiotics. Right? That's like the obvious treatment for pyelonephritis is give them antibiotics. But no, you have an obstruction and you have white blood cells and pus and bacteria behind the obstruction. So the antibiotics will not penetrate that pus or whatever, right? That's how I understood. So you give nephrostomy tube, you drain that shit out, and then you give antibiotics, then the patient is fine. That's like how nephrostomy tube used to treat this. Okay. Which of the following is the most appropriate next step of management? 45-year-old woman comes to the physician, 4 hours of right upper quadrant abdominal pain that radiates to the right shoulder. Okay. She has a fever. Why do we have a lot of cholecystectomy questions here? Physical examination shows right upper quadrant pain that improves with deep inspiration. Oh, that's interesting. Wow. Okay. Wow. Oh, bro, that's so interesting. Thanks for sharing that. Okay, that makes sense. Like, I used to be like them, give them antibiotics. I didn't understand the importance of nephrostomy tube. Okay, that makes sense. Which of the following is the most appropriate next step in management? Okay, wait. Preoperative ECG shows dropped QRS complexes preceded by PR intervals of regular intervals. The PR interval in the first beat after the block is similar to the PR after the block. The PR interval in the first beat after the block is similar to the PR interval before the block. Okay, that's just to say that this is type 1, right? Either type 1, oh, not type 1, it's Mobitz type 2. Mobitz type 2, yeah. Okay, so let me review the types quickly, because I don't remember them. Alright, so we have type 1. Type 1 is just you have prolonged PR intervals, right? You have just a little bit of time. It's just more time, right? Type 2, we have two. We have Mobitz type 1 and Mobitz type 2. Mobitz type 1 is just every PR interval, you know, one is like smaller, and then it enlarges over time, and then drops, right? Mobitz type 2, the PR interval is constant, so it's the same time, but you get like the beats skip, so you get skip beats. You have a P wave and you don't have a QRS complex. Type 3 heart block, there is no relation between the P and QRS. That's type 3, so type 1, type 2, and type 3. Okay, so this patient, it says the PR interval in the first beat after the block is similar to the PR interval, so that's Mobitz type 2. While being evaluated, the patient loses consciousness. Blood pressure is 85/56. Which of the following is the most appropriate next step for management? Okay, so I think that's just pacemaker, isn't it? Okay, wait a minute. What does this have to do anything with the right upper quadrant pain that radiates to the right shoulder? Dopamine? No way. Why dopamine? Was it blood pressure? Maybe it's atropine. I think so. I think it's atropine. Actually, you're right. You gotta treat the patient. He has a very low blood pressure. You gotta treat him right now. You don't have to give him like pacemaker. Well, pacemaker later. You're gonna treat him with pacemaker later, but you gotta rescue the patient. I don't think you're gonna defibrillate. Dopamine is not used here, I think. Wow, you're actually right. Damn, bro. Good job. Never mind. You're the boss here. Dopamine is used in type like AV block? No way. Mobitz type 2, second degree AV block. Dopamine, dobutamine, epinephrine. So how do you use atropine? I think it's type 1 then, right? Okay, I'm never gonna forget that. I'm happy that I got that wrong. Dopamine for Mobitz type 2. I mean, at least I got the type right. Mobitz type 2. As the patient stabilized, reversible causes should be investigated. If no reversible cause can be found. Okay, so type 2 is associated with reversible causes. And then if no reversible cause is found, you put a pacemaker. I used it for the BP. Okay. I mean, whatever, right? Like, you gotta get the question right. Doesn't matter. I don't think you get the dopamine for like for blood pressure. You can give epinephrine. I mean, not even epinephrine. You give alpha one agonist for hypertension. Okay, damn, bro. Ah, okay. So this part is just to like waste your time, basically. The question is right here. So he's preparing to get into the OR for cholangitis or cholecystectomy, and then they tell you, well, you know, that's the we gotta give him, we gotta prepare him. Morbid's type 2, second degree AV block is characterized by blocked QRS complexes preceded by PR intervals. Hemodynamically unstable patients with Mobitz type 2, second degree AV block should be urgently treated with a beta adrenergic agonist, dopamine, dobutamine. Okay, is it the same for the other types? Okay, let's read that. First degree heart block, monitor, no indication for a pacemaker. Okay, so first degree AV block, you don't give pacemaker, you just monitor the patient. So using ECG. Alright, that makes sense. Second degree AV block, if it is Mobitz type 1, only monitoring. If it's type 2, dopamine, dobutamine, epinephrine, and temporary pacemaker. If it's type 3, pacemaker, for sure. Yeah, I know that one. If it's type 3, definitely a pacemaker. Type 1, just monitoring. Type 2, Mobitz 1, just monitoring. Type 2, Mobitz 2, dobutamine, dopamine, epinephrine, or stable temporary pacemaker. Okay, let's write it down. Okay, type 1. Type 1 monitoring. Actually, type 1 and type 1 Mobitz also monitoring. Type 2, dobutamine, dopamine, epinephrine, or pacemaker. Okay, when do you give pacemaker? Oh, hemodynamically unstable, because he's hemodynamically unstable. So you're right about the blood pressure part, because he has low blood pressure. You gotta, like, he's unstable, so you gotta rescue the patient quickly. So dopamine, epinephrine. If he's stable, just treat the patient with temporary pacemaker. Okay. All right, I'm gonna mark this one. The surgical management of this patient's condition requires which of the following? Previously healthy 36-year-old woman comes to the physician because of worsening pain, numbness, blah blah blah. She noticed. Okay, so this is polymyalgia rheumatica. So worsening pain, numbness, and weakness. She notices the symptom worsen. Okay, no, that's not polymyalgia rheumatica. So she's presenting with just one arm, not both arms. So that's not polymyalgia rheumatica. Polymyalgia rheumatica, it has to be both arms. So that's just one arm. She has the strength is 5 over 5, so no motor weakness. Sensation to light touch and 2-point discrimination are equal in all dermatomes. of the bilateral upper extremities. Throughout the right upper extremity and mild weakness with thumb movement. Okay. Resection of a lymph node. I feel it. Is it like what is it called? Tendon tear. Hey Ezzo, how are you, bro? Tendinopathy tear B. That's not tendinopathy, bro. Come on, no way. I'll tell you why it's not tendinopathy. The patient has strength, normal strength, 5/5. She's just complaining of pain, numbness. Well, she has weakness too, but pain and numbness. Tendinopathy doesn't explain that. And also, where in the answer choices is tendinopathy? Happy Eid, Habibi. Resecting of a rib. What is it called? It has a name, like neck rib or something. Like the extra. I think it is. That's it. Okay, yeah. Thoracic outlet syndrome. Okay, that's it. Thoracic outlet syndrome, as multiple etiologies, in cervical rib. I was trying to remember that name. Cervical rib. Hypertrophy of scaly muscles. Neurogenic TOC may be caused by compression of the brachial plexus, lower trunk by an accessory rib. Surgical management focuses on resecting any accessory cervical ribs. That may also include partial resection of anterior scaly muscle. That's a nice emoji. Why not lymph nodes? I mean, do you have any condition in your mind that a lymph node can compress a nerve? I mean, unless it's like cancer or whatever. Like, okay, would be attempted if the patient were due to lymph. Oh, so I was right. I mean, she's not complaining of like growth of, or is it? Is what's common is common. I mean, she didn't present with any cancer symptoms, right? Oh wait, I think that like Panco's tumor. Do you know Panco's tumor? It's associated with Horner syndrome. Yeah, that's the only one I have in mind that can cause compression symptoms. Otherwise, that's yeah. Okay, that's an easy one. I'll just move on. Okay, which of the following is most likely caused the patient's death? Which of the following most likely caused the patient's death? Right. 24-year-old undergoing supraclavicular node biopsy suddenly dies from cardiac arrest after a hissing sound is heard. At the time of the event, the target node was under traction and the final cut was made. The patient was in. Okay. Okay, I'm guessing that's what is it? I think that's a embolism. Hissing sound, and he was inhaling. When you inhale, you increase the what is it called? The intrathoracic pressure, and that dilates the major veins. So if you made like a tear in one of the veins right here, let's say you're trying to remove the node, if you made a tear in the vein, that will pull the air into the vein, and then it will go to the heart. It will block the pulmonary artery, and no blood will go to the lungs, and no blood will come back to the left heart. So you'll get sudden cardiac arrest. I think so. I hope I'm not wrong after all that. Let's eliminate tracheal injury. Tracheal injury? Would it lead to cardiac arrest? Tracheal injury? No. It wouldn't lead to cardiac arrest. It would probably lead to like pneumomediastinum. I mean, pneumomediastinum. It could lead to pneumomediastinum. But I mean, supraclavicular is like right here. How do you reach the trachea from here? That's stupid. Sympathetic discharge. So neurogenic shock. You gotta hit the spinal cord in order to get neurogenic shock. I don't think so. Sudden pneumothorax with lung collapse. Sudden pneumothorax with lung collapse. The sound make me want to go for C. Sudden pneumothorax with lung collapse. I mean, that's a good answer though. Sudden pneumothorax. But they didn't say anything about like the Beck's triad. If you have tension, okay, let's say you have tension pneumothorax, right? They're gonna say you think A, arterial injury with air embolism. Okay, I'm gonna explain why I don't think it's C first. If you have sudden pneumothorax, like tension pneumothorax that will compress the heart, you'll have like dilated veins and stuff. Right? Don't you think? I mean, that's a weird question. Arterial injury with air embolism. If not for the sound, I go B. Why is the sound a problem? I don't understand. So the hissing sound is just the air bubble going into the vein. So arterial embolism doesn't work for a reason. The arteries, like, it's very hard to, first of all, well, no, they're not good. Like, okay, first of all, like, there is a pressure, right? So in the artery, it's very difficult to push a bubble into an artery. There's like increased pressure. Okay, let's say what's the answer before I start like explaining. Okay, I was right. That's perfect. Okay, yeah. So I'll make a guess about why each answer is wrong, and I'll see what's the correct explanation for it. Arterial injury, it's not the correct answer because the artery has a pressure. It's very difficult, like you have to decrease the pressure in the artery in order to absorb the bubble, right? You have to have that. Let's see why A is wrong. Okay, never mind. Yeah. I'm not gonna lie, and that's not to brag or whatever. I thought about this. I thought about if it's going into an artery, it's also going to go to another organ, not the heart itself. So it's not gonna cause a sudden cardiac arrest. It's gonna just block another artery. No, it's not. A as arterial and cholesterol. Yeah, perfect. Yeah, correct. Yeah, you're right, Miriam. Why is it not? This is not neurogenic shock. Neurogenic shock, you'd have to hit the spinal cord. Yeah, from the spinal cord and sympathetic chain. Or the sympathetic chain. You have to hit the spinal cord or the sympathetic chain. Okay. Let's see the next one. Which of the following is the most predictive factor for intra-abdominal injury? One second, my phone is ringing. Abdominal examination shows distension, jointless tenderness, palpation. Oh damn, that's a hard one. Abdominal distension. Most predictive. Low hematocrit. I mean, he could have like anemia before that, right? Don't think so. Leukocytosis. No. Abdominal guarding. I mean, sure. That would lead to peritonitis. Abdominal ecchymosis pattern. This could be like the Gray Turner sign, or what do you think? B? Really? Think B? Abdominal distension? Okay. No way you're right, guys. Abdominal ecchymosis pattern. Is that like the seat belt sign? Let me see the seat belt sign. Wow, it's indicative of internal injury. Okay, I think you're right. Okay, I thought it's C, so I'm gonna pick C, even if it's wrong. Okay, you guys are right. The correct answer is B. This adult patient is presenting after a mortal blunt abdominal trauma. Seatbelt, yeah, seatbelt sign. I know it's seatbelt sign, but I thought seatbelt sign could indicate anything. That's why I didn't pick C. BP is good. Where is the BP? Let's see why C is wrong. Voluntary gardening. Okay, voluntary gardening. Okay. All right. I think I got that. Good job, guys. Which of the following is the most appropriate next step in management? All right, that's definitely. Okay, that's stupid. Laparotomy. Don't you think? Laparotomy? Damn, bro, you're Alexandria University? What year are you? I think it's C2, right? Okay. Alright. I suck at this. No, it's CT, bro. Oh, because he's stable. He's stable. He has, like, blood pressure is normal. So there's no reason to do laparotomy right away. CT is going to be helpful to identify where the bleeding is. Okay, no, that was dumb. Okay, laparotomy is reserved for severely and indications include hypotension, peritoneal signs. Okay, so that's why it's not C. My bad. So that makes sense. Makes sense. CT. Patients with trauma and high likelihood of intra. Yeah, right. Hemodynamic is stable. He's stable. So CT is going to be helpful to identify where the bleeding is. Yeah, guarding is not like rebound tenderness or rigidity, for sure. Right. It can be just from pain. Right. Yeah. Yeah, CT, we just didn't focus. Yeah. Yeah, I honestly just wanted to get rid of that block. It's full of mistakes, actually. So I have a weakness in surgery because I used to like skip surgical rounds. I don't remember what I was doing at that time, but that's why I'm doing like focused surgery blocks. Let's end that block. Okay, actually not bad. Okay, let's do another block. I finished. So I have like I have what? How many questions left? I have like 1939 questions, so 1,939 questions, and I only have like 20 days left to do them. So I have to do at least 100 questions a day. So I did 20. I'm gonna do 80. So let's do that. Should I do everything or just do unused? Okay, let's do unused. Actually, I'm not gonna do them Thanks, bro. I have to get some coffee though. I'm gonna go get some coffee. But let me just create the tutor mode. Okay, so I have a weakness in gynecology. So I want to do like gynecology today. I'm very good in internal medicine, emergency, and family medicine. I do like very few questions wrong on these because of step 1. But gynecology, I suck at this. Also obstetrics. Pediatrics a little bit. Psych is good. So let's do let's finish gynecology. Okay, let's finish gynecology. I don't know, remember, I think that's 31st or something. Oh wait, I'm actually not as bad in gynecology. I'm bad at, let's do OBGYN. Let's do OBGYN. Unused. Hard, easy, okay. Tutor mode, 40 questions. I'm just gonna get coffee quickly and then come back, okay guys? Feel free if you want to leave, it's fine. If you want to stay, I'll be happy. Not gonna be late. To the following is the most likely diagnosis. 4 hours, right lower quadrant, pain sharp, suddenly, course. Okay, while she was having intercourse. So sexual activity, I mean, body activity, or exercise, whatever. I think it's just torsion or rupture of a cyst. Patient sexually active. Spectrum examination shows a normal cervix and a vagina. Right adnexal tenderness and no adnexal mass. Appendicitis? No way. I think so. Adnexal torsion. Mittelschmerz. No. That is what is that called? The pain just before the the ovulatory pain when the ovary hits the ovum, whatever. It's not that. PID, no. Endometriosis. Okay. Why it's not A? B. Can present with acute right lower quadrant. However, this is typically tender adnexal mass, because no adnexal masses. Oh. Yeah. Because the pain is mid-cycle, yeah. It's so weird. 4 hours. I thought middle, whatever it is, middle schmerz, just a transient pain. I thought it's like very subtle, not 4 hours of lower quadrant pain with mild nausea. Like, what the hell is that? Okay, I've never seen a case of middle schmerz. So whatever. This patient presents with 4 hours acute onset mild right lower quadrant pain 2 weeks after her last menstrual period and adnexal mass without obvious amniotic abnormalities. This presentation is characteristic of middle schmerz. Ovulation. That's the pathophysiology. Wow, the pain that can actually stay for 1 to 2 days. Peritoneal inflammation. Follicular rupture also results in the release of a small amount of follicular fluid and blood, which can cause peritoneal inflammation, can manifest as acute onset, mild to moderate unilateral pelvic pain that can last as long as 1 to 2 days. Although, okay, some women experience that with every ovulatory menstrual cycle. Okay, pelvic pain that occurs as a result of ovulation. Acute onset, mild to moderate unilateral pelvic pain. It's 2 weeks after the menstrual, lasts several hours to 2 days. I didn't know it can result in that severe pain. Pelvic examination shows tenderness, no obvious anatomical abnormalities, normal pelvic ultrasound. Ovulation releases a small amount of follicular fluid and blood into the peritoneal cavity, which can cause inflammation. Treatment reassurance, consider pain medication. Okay. Research MD. What is Research MD? I've never heard of that.
Hi everyone, welcome to researchmd.com. We got a great presentation today. My name is Dr. Pramil Chariat, and today we're going to talk about how to write a letter to the editor. Remember the previous presentation we talked.
What's that, bro? I've never heard of that. Is that like a research service where you can publish research? To be honest, I've never tried it personally. I didn't want to involve myself into research at all until I finished step 2. So I want to get a very high score in step 2, and then I'll see what research I'm gonna. Where do you live? Do you live in outside the U.S. or inside? If inside, you can easily get a research position here. Holy, $400. I don't know. I have no idea, to be honest. In Greece? Do you have any visa to come to the US? Welcome back, bro. Sorry I couldn't help P. Mila. If I heard anything, I would let you know, for sure, in the next stream. If you can come to the US, definitely come here. As an IMG, you can easily get a research position. Don't worry. Just do step 1, 2, get a good score, and apply for research positions. Very easy. Okay. So, Fanta Zemk. Bro, just tell me your name. What's your name? Of course, no problem. You're welcome. Fanta Zemk. That's a funny name. Okay, so I got this question wrong because I didn't imagine how Mittel Schmers could present. That's fine. It will be like in the beginning it will be unpaid, and then they will pay you for your service. But you cannot like expect to do any. You wouldn't want them to pay you because you have no experience. Like if you haven't published research before, research is difficult and annoying. So yeah, like you can do anything on the side. For example, I have a course that I sell. I make good money from it, right? For step 1. So do anything that helps you get money on the side, and don't worry about like research for money, right? You can work as a medical assistant. You can work as a medical scribe, that transcribes some stuff. There's a lot of things to do to make money. So don't worry about money. That I need as a trainee. I think 6 months. If you don't have any experience, 6 months is good for you. So yeah, 6 months there, because when you do 6 months, like they will need you. Yeah, of course, they're very easy. If you are here in the United States, if you're here, like, that's done. Like, you can get these positions. Yeah, you can do them in parallel to research, yeah. I mean, it depends. Like, you could get a medical assistant job at night, for example, like from 6 p.m. to 12 p.m. I mean, it's going to be difficult, but when you have this in mind, like the motivation stuff, you're going to be motivated to do a lot of these things, like when you have your goal in your mind that you want to become a U.S. resident, you want to make good money. Physicians here make a lot of money, etc., etc. It's gonna be easy. All right. Let's see. Okay, Omar. I'll call you Omar, man. That's easier. Which of the following is the most appropriate next step in management? All right, negative. The blood type of her first 2 children are unknown. 32-year-old woman, gravid 3, pair 2, comes to the physician. The patient has had no pain or vaginal bleeding. She has not yet felt the baby move. She takes a daily prenatal vitamin, has no chronic medical conditions, and has had no prior surgery. Her temperature is 36, blood pressure is blah blah. Fetal heart rate is 150 by Doppler ultrasound. Routine. Okay, her blood type is A, RH negative. Okay. – 14 weeks of gestation. Okay, what? Varicella zoster immunoglobulin? What the hell is that? Are you working currently that you are in the US? No. I thought about doing the medical assistance thing. I had a job actually that I applied for, and I got it. But to be honest, I thought it, from 9 to 5, that's like 8 hours of work. So I would rather do this. I would rather study myself than go work for someone else. So no, I'm not doing anything beside my tutoring business. It's very good. In addition, I make some money on the side too, like from other sources. Like all you need is pay your rent and have food, and that's all you need. Pretty much, right? It's gonna be hard in the beginning, I swear, but it's worth it. Are there any requirement to apply as an assistant? No, you have to have like some medical terminology knowledge, and you'll be all set. You don't need any requirements whatsoever. So, all right. I feel like this is a trick question, I don't think it's varicella zoster immunoglobulin. Tetanus, Tdap. I mean, we give Tdap in pregnancy, so I'm not going to eliminate that. MMR. Isn't that a live vaccine? That's contraindicated, isn't it? An influenza vaccine. We have 3 options to choose from. I didn't memorize that's what I hate about step 2, is that you have to memorize these things. 14 weeks of gestation, so that's like what? That's first trimester. I don't think you give ROGAM the first trimester. Tdap. I think so, Tdap, because it's first trimester. I gotta review this for ORH at 28 weeks. Yeah, I think so. Okay. This question is like, Ahmed. So what does Fatima do? Road is 10 in 28 weeks. Yeah, see these things. I didn't memorize. Like I haven't gone through them. So you tell me. So it's C, isn't it? Okay, let me pick C. Okay, good job, guys. All right. Influenza. Is more likely complicated by hospitalization, pneumonia, intensive care unit. In addition, pregnant women. Okay, why is it not Tdap though? Indicated for or pregnant in order to prevent neonatal pertussis. The optimal time to administer the vaccine is between 27 and 36 weeks of gestation. Oh, it's you cannot hear it? I'm using a microphone. Sorry, maybe the microphone is a little far. Can you hear me now? Let me see what am I using? Hello. Okay, can you hear me now? That's fine, $1. Bro, you're my student, that's fine. We're here to learn. Okay, so tetanus or Tdap is at 27 or 30 weeks gestation. And ROGAM is 28, like you guys said, 28. So 28, 20. Okay, so Tdap and ROGAM are like at the same time. Okay, let me actually think why is that the case. So ROGAM, why is it in 28 weeks? Okay, so now your voice is so far, really? Okay, wait a second. Oh, sorry, I think I lowered it, my bad. Yeah, is that clear? Is that better? Okay, we're gonna finish that, guys. Alright. The blood types. Okay, let me write that down. Where's that? Tdap. 28 weeks. Flu vaccine as early as possible, okay? And ROGAM, ROGAM is 28 weeks. And Tdap is from 27 to 36. So we're talking about third trimester. Or late second, third trimester. ROGAM is 28. Tdap is 27 to 36. Yeah, that's just a memorization question. I gotta know. Flu to not make her ill during pregnancy. Yeah. The correct answer is A. Influenza during pregnancy. Okay, let's move on. It's just a memorization question. Which of the following is the most likely diagnosis? Which of the following is the most likely diagnosis? Alright, let's see. 39-year-old woman, urinary hesitancy and constant dribbling that began several months ago. The patient has had to wear adult diapers. Her menses are regular, occur every 27 days and last for 7 days with heavy bleeding for the first 2. Okay. She had 3-term vag, blah, blah, blah. She has sexual, blah, blah. She does not smoke. She drinks beer on weekends. She has 3 cups of coffee during the day, 2 cans of cola in the evening. Her temperature 36. blood pressure. On physical examination, normal heart sounds are heard with no S3/S4. Her chest is clear to auscultation. Enlarged anti... Several months ago. Several irregular protrusions. Wow, okay. That's a lot of blood that remained. Probably overflow incontinence. Right? Yeah. I think it's B2 because even after she voided, we still catheterized the woman, and she drained 224 milliliters of urine from the bladder. So that means she couldn't remove these 224, right? God, ya Rabbi tabqa صح. Oh, alhamdulillah. Okay. This patient most likely caused by bladder outlet obstruction from uterine fibroids. Yeah, I thought that because of the several irregular protrusions. 3 notes for you. Your voice, use a microphone. Your head is on the answer section, so no one can read the answers completely. You can only read half the lines. Okay. So the answers, you mean the explanation section or the answers here? You know what? I can move my, okay, I can make myself smaller like that. What do you think? That's better? Okay, I'll do that, and that's better. Okay. All right. Thank you, guys. Okay, overflow incontinence. Let's move on. Which of the following explanations? A pelvic ultrasound confirms a left-sided adnexal mass. Which of the following is the best next step of management? That is an abscess, right? That's abscess in the ovary or in the fallopian tube. Like pelvic inflammatory disease. She's stable, so the blood pressure is 110. Emergent surgical evaluation. Monitor the, okay. Discharge the patient after management. She already was given antibiotics, but it didn't work. So pregnancy test, then CT. She has an infection. She probably has a pelvic inflammatory disease that turned into an abscess. Yeah, multiple sexual partners. That's definitely PID. Outpatient? I'm not sure it's outpatient. It says high fever. Okay. Yeah. All right. Tubal ovarian abscess. PID complicated by tubal ovarian abscess, abdominal pain, vaginal discharge, blah blah blah. Amateur disease. Other indications for inpatient management: pregnancy, non-compliance, inability to tolerate oral medications, needing invasive evaluation. Okay, these things need to be memorized. What the fuck? Okay, management, outpatient, unless. Okay, PID. How to? That's so high yield. I didn't catch the multiple partners. Yeah. I mean, what else could it be? There's a vaginal discharge. Acute infection of the upper female genital tract. Polymicrobial infection caused by STD, chlamydia, trichomonas. Okay, management. Outpatient unless pregnancy. Unable to tolerate oral antibiotics. Severe symptoms. Pelvic abscess. Yeah, an abscess is just yeah, you can't just leave that out. You gotta treat it inside. Antibiotics. Outpatient. Ectopic or endometriosis, that will not cause a fever. There's a fever here, so that's. Thank you, Rafik, for letting me know. That's a nice feedback. Thank you. Okay, so, all right. Which of the following is the most appropriate test for? My voice is very low. I mean, Omar thinks my voice is good. Maybe the problem is in your speakers. I'll try to see if I can like increase the voice here. 1 second. Hello. I mean, it's like maximum volume here. Hello. Is that better? Okay, let me check. Maybe the mic, like my mic is not this mic, because this mic, maybe it's the mic in my headphones. Let me check. If it's my headphones, the audio quality will improve. 1 sec. Okay, I'll try to raise my voice then. All right, which of the following is the most appropriate test for this patient at this time? Let me see. Where's the mouse? Okay. Which of the following is the most appropriate test for this patient at this time? A physical examination is normal. A depression screen is negative in addition to a testing of HIV. All right, 21-year-old, annual examination. The patient feels well. No chronic medical problems, no previous surgery. The patient has received all her vaccinations, including vaccination against HPV. She's sexually active, one partner, internal device. Depression screen is negative. Okay, so she has vaccination against HPV. I think syphilis is a must, right? Oh wait, she's not pregnant. Annual examination, 21-year-old woman. Okay, one sec. Okay, she's not high risk of hepatitis B. She's not like IV drug user or whatever. Herpes simplex virus. She has just one partner here. She's not complaining of any symptoms. I'm not gonna look at your answer, guys, so I don't get any hints. I'm gonna try to solve it on my own and look at your answers. Human papillomavirus test. She has a vaccination, but she's 21. She should get. I mean, these two answers are like each other. It's a difficult one. Rapid plasma reagent test. Oh sure, that's syphilis. Do we do syphilis screening on women who are not at high risk of syphilis? She's not like, she only has one partner. I don't think it's syphilis, to be honest. HPV test, pap test. These are the same. Like, these are both screening. Maybe pap test. Okay, damn, got it right. Shit. Okay, wait. Is it important to do Kaplan for step 2? To be honest, Kaplan is very cheap. Like, it's $160 for 3 months. So that's why I got it. Really, just because it's cheap. In addition, I want to get like a 270 on step 2. I'm thinking about orthopedic surgery as residency. So I want to get like all my options open. So I want to finish all question banks. I want to finish Kaplan. I want to finish Amboss, UWorld, RX, like everything I can. That's why I'm doing Kaplan. Where's the complaint? Yes, E. No, bro, it's not E. Okay, E, B, and A are out of the way. Because I'll tell you why. E is done when she's pregnant. You do syphilis on women if she's pregnant. Okay, I go B. Herpes simplex. There is no symptoms. We don't usually do HSV screening. It's better when you said hello near the microphone. Like that. Okay. I don't know, maybe I'll just I'll do that. Okay. PEP is better from yeah. I'll tell you before we read the explanation. I'll tell you why I picked PEP. HSV. She's already okay. Let me see why it's not. Yeah, so like I said, high risk for transmission, so HIV, history of sex work, multiple sexual partners. Same thing as hepatitis B, we do screening only if she's high risk, like multiple sexual partners, IV drug use. We don't do her HSV serology unless she has symptoms, like she's complaining of symptoms. And yeah, all right, let's talk about this, because this is high yield. This is very high yield. I saw like 10 questions of this. So, okay, I'll tell you what I remember before I read the explanation. I can hear your thoughts, man. Thank you. You can use a mouth microphone, which can be adjusted near your mouth. I don't know what to do, bro. Really. Let me see again. Maybe the settings are bad. Really? It is that low that you're complaining? Is it like that low? Okay, let me raise it. Maybe there's a way. Maybe there is a way. Is that better? Hello? Is that better? Hello? Is that better? Hello? Is that better? High yield sources, please. Kaplan is high yield. Kaplan is very high yield for step 2. I wouldn't do it. Like, I wouldn't waste 2 months doing it if it's not high yield. Thanks, bro. Yeah, I think my mic is good. I don't know why. All of the high yield sources for step 2. Please, Joe. Do you want me to tell you all the high yield resources for step 2? Okay, so step 2, you don't do like reading no more. It's done. Reading is so not useful for step 2. It might be good for step 1 because you're still learning the information. But for step 2, no. You only do question banks. So you do Kaplan. If you have if you have 1 year, for example, a complete year of preparation for step 2, do all the question banks you can. So it's gonna be helpful. If you have like 6 months, 4 months, 3 months, just do UWorld. Okay, and try to do 2 blocks a day at least. I'm doing 100 questions a day, so I'm gonna finish quickly. So this is high yield. It's gonna come up again. Where's my okay, so what I remember is that starting 21 years, we have like a screening recommendation for young women. Starting 25, and then starting 31 or 30, something like that, and then more than 65. Okay. So Pap test and HPV test are both screening tests. Both of them are screening for cervical cancer. You're welcome, Amr. All of them are, both of them are screening modalities. Less than 21, it's not indicated. So starting 21, we actually start screening women for cervical cancer. Okay. Before that, you don't give screening. 21 to 29. 29. Okay, it's not 25. Yeah, so we have 29 here. Okay, so 21 to 25, and then we have 29, and then we have 30 to 35. Okay, so in 21, we do Pap test. 25, we do HPV test, right? Or Pap test. 29, you can do co-test, I guess. Yeah, co-test. So HPV or PAP or co-test. And 30 to 65, more than 65. I think no need for screening unless she has like multiple sexual partners or whatever, right? If inadequate screening. Yeah. So I'll just memorize it like that. More than 65, no need for screening, okay, unless otherwise specified. So 21 PAP test. Okay, let's memorize it. PAP baby for like 21 baby. And then 25 HPV or PAP. 29 you can add co-test because she's like old woman now. Okay, so yeah, I'll just memorize it like that. Let's see next question. Which of the following is the best next step in management? 27. Okay, she has a positive RPR test. A bedside ultrasound shows an 11-week intrauterine pregnancy. Okay, which of the ones is the best next step? Okay, RPR is a screening test. Does it need a confirmation? I think it needs confirmation, right? Okay, that's not true. That's definitely not true for a reason. If she's pregnant or she has CNS syphilis, you have to give her penicillin, even if she has a penicillin allergy. You desensitize her and then you give her penicillin. So it's not the venereal disease research from. Both of these are confirmatory. One to 4 titer. I don't know. Should I pick that? Should we just treat for syphilis, even though we're not sure if it's like the correct answer? Sorry, if she has syphilis, should we just treat it? RPR is for screening. I'll try to come near the microphone. Oh, okay. Maybe it has like a noise cancellation where if I like came like this, it decreases. I don't know. Thank you so much, Crypto. Should I do only anking or should I use first aid revision too? You can, if you have a good medical foundation, you can just use anking. You can just completely avoid first aid. Even if you have like a bad foundation, first aid is not good, right? So anking is just to keep the information fresh in your head. I don't know. I mean, E. So this is a positive screening test. E, both E and C is confirmatory tests, right? So I think C and E are both wrong because they are both the same. Or I'm just dumb. Either or. Okay? So I'm just gonna go for that. Bismillah. Okay, I'm dumb. Okay, why it's not E then? Ooh, okay. VDRL is actually a screening test for syphilis, not a confirmatory test. I thought it's a confirmatory test, my bad. So you see why it's wrong now, guys. So VDRL is screening test 2. So FTA, ABS test, and VDRL both are screening tests. Okay, screening test. I didn't remember that one. All right. So what I picked is the treatment for syphilis, and this is high yield. If you're gonna get something from this stream, get this. If the patient has syphilis and she's pregnant, even if she's penicillin allergic or she's allergic to penicillin, it doesn't matter. You're gonna give her penicillin as the treatment, but you have to desensitize her first. Okay. Which of the following is the best next step in management? Okay, the symphysis fundal height is 26 while she's 30. The normal is less than or equal to difference. So if she's 30 weeks, the fundal height should be like 28 minimum. Ultrasound shows fetal and vertex presentation, so normal. The ultrasound estimated fetal weight is at Gaza. Which of the following is the best? Wow, okay. Why not A? They're saying that it could be fetal in origin or placental in origin. A means it's fetal in origin. Okay, so FGR attributed to fetal cause is not amenable to antepartum intervention. So even if the patient has a fetal cause of fetal growth restriction, they can't do anything. That's what I understand from here. Let's see, why is it not A? Okay, so in order to do amniocentesis, you have to have ultrasound evidence. That's just fetal growth restriction. Contraction stress test? What is that? Rather than the contraction stress, antepartum fetal surveillance with FGR typically involves the use of Okay, yeah. What is the contraction stress test? Oh, okay, so that's just the non-stress test. Okay. Okay, so just know this piece of information. All fetuses with fetal growth restriction should undergo umbilical cord Doppler sonography to assess for evidence of utero-placental insufficiency. Okay, fine. Which of the following is the most appropriate next step in management? Okay, so she's 24. She has done a pap test 3 years ago and it was normal. Okay. Co-testing is done at 29, so it's not co-testing. HPV is HPV test is done 25, right? 25. HPV vaccine, she's already on it. So we can do another pap test, right? Okay, yeah, because it's every 3 years. So it was normal 3 years ago, and now we got to do another one because you have to renew it every 3 years. Okay, recommendation for when to start testing. Okay, let's review that because this is so high yield. Less than 21 years old. She doesn't need any screening. From 21 to 29. Starting 25 years old, you have to do an HPV test. Okay, you can do HPV every 5 years, or you can still do Pap test every 3 years. You guys are saying C, no intervention. I mean, yeah, I would have picked that if I didn't know the table. Pap test every 3 years, HPV test every 5 years, HPV test every 5 years, or co-testing every 5 years, or Pap test alone every 3 years. Okay, that's easy. Which of the following is the best next step? Which of the following is the best next step? 16-year-old. She experienced sharp lower abdominal pain that started an hour ago. Suddenly and is constant. Her period started today. Okay. But her last period was over 8 weeks ago. She feels nauseous, but not vomited. She has an episode of pelvic inflammatory disease. Probably a rupture. A rupture of, okay, serum beta HCG is 3,600, so probably a rupture of ectopic pregnancy. Transvaginal ultrasound shows a gestational sac with a yolk sac in the middle. Portion of the, okay, that's definitely, what is it called? Ectopic pregnancy, right? Moderate amount of bleeding is noticed from the vaginal opening, whatever. On abdominal examination, there is mild distension of the lower abdomen associated with tenderness in the right lower quadrant without guarding or rigidity. So it ruptured, but it didn't result in peritonitis, which is weird. Okay, let me think. Okay, she has a pelvic inflammatory disease. That's actually a risk factor for ectopic pregnancy. PID is a risk factor. There is mild distension of lower abdomen associated with tenderness. That's weird. I don't understand why there is a sharp sudden lower pain, even though there is no guarding. So I think laparoscopic surgery is misoprostol. I don't think so. This is for like normal pregnancy, isn't it? Method. Okay. Oh, go B then if there is imaging that indicate bleeding. I mean, yeah, I would think that, but you know, there's no guarding or rigidity. I don't think it's expectant management. Okay, I'll say laparoscopic surgery. Maybe it's gonna rupture later. Expectant management? You're gonna leave the woman with a ectopic pregnancy? No way. No way is right. Okay, so yeah, you're right. Method checks here. Okay, why is it not A? Expectant management would be inappropriate as she has confirmed ectopic pregnancy. Okay, so there is no way it's A. Laparoscopic surgery would be the appropriate option if she was hemodynamically unstable. Yeah, that's true. Yeah, so mifepristone and misoprostol is for termination of intrauterine pregnancies, so normal pregnancies. That's not the medical abortion in the United States. Misoprostol alone. Okay, so it's not used. You use mifepristone and misoprostol. Mifepristone is an anti-progesterone. I'm afraid for her tubes, so go B. Bro, you were right. You don't doubt yourself. It's C. 1 second, guys. My phone is. Okay. Muhammad said C. Good job. Yeah, it is C. It's just so weird because she has a sudden onset pain. So I thought, okay, maybe it ruptured, but it didn't like spill, you know? You would still want to go in with surgery, but obviously not. So she's stable, so she could. Wow, okay. All right, let's just move on. So she doesn't have. Okay, so 2 things, right? First of all, her what is it? Beta HCG is less than 5,000. So if that's the case, you can give methotrexate. Of course, in addition to that, she's stable. So less than 5,000 and she's stable, you can give her 1 dose of methotrexate. Okay, so move on. Alright, which of the following is most likely to occur if this patient's condition is left untreated? 28-year-old teen, sexually active, non-tender right adnexal mass, screening for STD is negative, pelvic ultrasound 5 centimeter, cystic mass in the right adnexa. The mass is heterogeneous, containing hyperechoic nodule, has multiple hyperechoic lines. Is that an ovarian cyst? 5 centimeter cystic mass in the right adnexa. The mass is heterogeneous, containing hyperechoic nodule, and has multiple hyperechoic lines. I think that's just a cyst. No chronic medical conditions, routine health examination, withdrawal method of contraception. Hemoperitoneum, intraperitoneal abscess. Okay, let's just go for resolution of the mass. Ovarian necrosis. What do you guys think? Maybe it's related to level of HCG. If it's yeah. E, right? I think it's E2. It's just a ovarian cyst. But 5 centimeters is actually big. It's like this. How large is the ovary? One second, my second screen is actually gonna die. 1 second. I have to put in the charger. Alright, let's just about 6 centimeter. Wow, it's like the ovary size. Okay, let's see. Oh no, okay. Yeah, it makes sense. It's very large for a cyst. Cyst is like it's the ovum size. So this is very large for a cyst. Okay, whatever. This patient presents with an she's young. She's 28-year-old, which is a risk the typical epidemiology for teratomas. It's 28. This patient presents with an asymptomatic right adnexal mass, which measures 5 centimeters, appears cystic and heterogeneous, hyperechoic, and multiple hyperechoic lines. This ultrasound appearance is consistent with a mature cystic teratoma. Hyperechoic nodule. Okay. Alright. Heterogeneous cystic structure. Yeah, and it's a risk factor for ovarian torsion too. Okay, let's see how does a ovarian cyst looks like ultrasound. Yeah, see, it's just full of fluid. It doesn't have like multiple lines. See? Okay, let's see teratoma ultrasound. Yeah, it's like a solid structure. The other OP is not, maybe it's related to level. Okay, will be homogeneous, I think. Yeah. Alright, whatever. Okay, let's move on. I have to finish like 80 questions. I have to move faster. Which of the following is the most likely cause of this patient's condition? Transvaginal ultrasound shows an empty uterine cavity. Quantitative beta HCG is 2,564. Okay, that's ectopic pregnancy. Okay, let's see. Worsening, crampy lower abdominal pain, passage of blood clots. Her last menstrual period was 6 weeks ago. The patient takes no medications, has no chronic medical problems, has had no prior surgery. Blood pressure, wow, blood pressure is actually low. Just can amount of blood in the posterior vaginal fornix. Okay, that's cause. Is that like just an easy question? That's hydatidiform cyst. That will be like in the thousands, like 100,000, 50,000 beta HCG. So it's not to say ectropion of the cervix. I don't know what that is. Cervical insufficiency. That wouldn't lead to ectopic pregnancy. That just lead to abortion. Autosomal trisomy. Down syndrome. What the fuck is that, bro? Okay, evaluation shows an open cervix. Where's the open cervix? Oh. 1 centimeter dilated cervix. Oh, okay. Yeah, that's abortion. Shit. Yeah. Okay, that makes sense. Approximately half of all recognized spontaneous abortions are attributed to chromosomal abnormalities. It's because the baby doesn't
grow to its like normal size, or like it cannot grow with a chromosomal abnormality. The most common are autosomal trisomies: trisomy 13, trisomy 18, trisomy 21. Just checking to see if you guys have. Right, the most common type of chromosomal abnormalities seen in first trimester abortions is autosomal trisomy. Complete spontaneous abortion can present with lower abdominal pain, vaginal bleeding, and dilated cervix, and ultrasound showing an empty uterine cavity. The most likely cause of early complete spontaneous abortion is a chromosomal abnormality. Okay, the most common type of chromosomal abnormality seen is autosomal trisomy. Okay, so definitely not A, because the cervix is dilated, right? So the babies just fell out. Okay, which of the following is the most likely diagnosis? A 38-year-old woman because of burning sensation during urination, vaginal discharge for 2 days. She's 38, so it's probably not vaginal atrophy. Trichomoniasis, chlamydia. Candidly, the pH should be higher, I think, right? Candidly, pH should be more than 5.5. Chlamydia cervicitis. Chlamydia cervicitis. I don't think it would present with white discharge. And the vaginal mucosa is actually is the inflamed part here. Like the labia majora is the inflamed, not the cervix. It's either this or that. There's one that presents with the green discharge. Is it trichomoniasis or bacterial vaginosis? Happy Eid, bro. Happy Eid. Thanks, Omar. I really appreciate you being here, bro. Take care. I'll wait for you for the next stream. Inshallah, I'll finish the 100 questions. I'm not going to leave before I finish it. So. Okay, bacterial vaginosis, trichomoniasis. There's one that presents with white discharge. I think it's this. Oh, this. I don't know. The thing is, how would she get trichomoniasis? That's an STD. Let's go with A. What? Damn. I thought that Canada is more than 4.5. There's a your picture, I like it. Where is it? Oh, damn, yeah. I know that Canada is normal pH. I know that. But in my head, the normal pH is like close to neutral. But for the vagina, the normal pH is actually acidic because there's some lactobacilli in the vagina. So Canada is close to 4. So from 3.8 to 4.5. Trichomoniasis, yeah, it was green. That's what I remember. Green discharge. Okay, that makes sense. Okay, let's move on. Which of the following is the most appropriate next step in management? 37-year-old woman. Atypical squamous cells of undetermined significance. What's that? Typical squamous cells of undetermined significance. So the last one was 5 years ago. So from 31 to 30 to 39, she gotta do, I think, HPV test. Okay, yeah, that makes sense. Atypical squamous cells of undetermined significance, which of the following the most appropriate next step of management? Okay, 1 second, guys. I'm gonna answer the phone. Sorry about that. Okay. All right, so I got that. I got what that means. One sec. I'm gonna get my screen here in order to see the chat because let's see. Right. So they're saying that for cervical cancer to happen, we have two risk factors. Either we have HPV virus infection, or we have atypical squamous cells. Typical squamous cells. But the thing is, atypical squamous cells could be either caused by neoplastic changes, so actually like pre-malignant or pre-malignant cervical cancer, right? Or what's that? Or dysplastic cells, dysplasia. So that's dangerous. Or it could be just not cancers, not because of cancer, not because of HPV, right? So if you ever found atypical squamous cells on an HPV test, on pap smear. Pap smear are basically you're taking a scrap of cells from the cervix and you're looking under the microscope, how do they look like. So if you found any atypia in that pap smear, you're going to do an HPV test in order to make sure, well, are these atypical squamous cells because of HPV? If they are, now you will do colposcopy. Okay, colposcopy and biopsy, I think, right? Okay. Let's carry on. So the following is the most appropriate screening modality for ovarian cancer. 60-year-old woman. Her friend. I don't think there is any screening like don't think there is any screening needed for this patient here. She doesn't have a family history. She's scared. She's just scared of ovarian cancer. Yeah. Asymptomatic without family history of ovarian cancer, no benefit for screening. Risk factors include history of ovarian cancer, BRCA or BRCA2 mutation, hereditary non-polyposis colorectal cancer or Lynch syndrome, increased ovulation through life, so nulliparity, right? This woman, I guess. In the 7th decade. Okay.
She has proteinuria. Low hemoglobin. What do you guys think? I don't really know. I told you I suck at obstetrics. Epidural analgesia. Let's remove general anesthesia. Okay. Why is epidural anesthesia associated with hematoma?
I want to sleep so bad. Gonna finish these 100 questions. Oh my god. I'm gonna finish till question 20 and go to sleep. Okay, this is rupture of membrane, premature rupture of membrane. There's infection, chorioamnionitis. How do you treat that?
What's antiphospholipid syndrome? It's easy. Damn, I'm dying. I want to sleep so bad. She's 61, and her last menstrual period was 8 years ago. She's bleeding so bad. Is that endometrial carcinoma? Large uterus, huge uterus. I feel like it's D. Okay.
Oh, okay. I'm gonna take a break. I'm gonna go to the bathroom. Actually, I'm gonna go to sleep. I haven't slept since yesterday. I'm gonna wake up, continue doing these questions, and I'll do another stream. See you guys in the next one. You know what? I'm not gonna be a pussy. I'm gonna go to the bathroom and then come continue. I don't care. One sec. Gonna come. Okay, I'll have to sleep now. I'll continue tomorrow. Or not tomorrow at night. Okay, I'll have another stream.
لكن لا
Sign out.
يعني في سيشن